Hello, everyone, and welcome to today's webcast, Managing ICU Arrhythmias, Rapid Rate Control Strategies Using Beta-1-Selective Agents. This webcast is sponsored by AOP Health. My name is Emily Highsmith, and I am a clinical pharmacy specialist in critical care and nutrition support at the University of Texas MD Anderson Cancer Center in Houston, Texas, and I will be moderating today's webcast. A recording of this webcast will be available within 5 to 7 business days. To access it, log in to mysccm.org, navigate to My Learning tab, and select Managing ICU Arrhythmias, Rapid Rate Control Strategies Using Beta-1-Selective Agents. Then, click the Access button to view the recording. Thanks for joining us. A few housekeeping items before we get started. There will be a Q&A at the end of the presentation. To submit questions throughout the presentation, type into the question box located on your control panel. Please note the disclaimer stating that the content to follow is for educational purposes only. And now I'd like to introduce your speakers for today. Each will present their information, followed by a Q&A session at the end of both presentations. First, we have Dr. Michael Bristow, who is an MD PhD and the Director of Pharmacogenomics at the University of Colorado Cardiovascular Institute, and followed by Dr. Jean-Luc Falahi, who is also an MD PhD and is a Professor of Anesthesiology and Critical Care at the Louis Pradel University Hospital in Lyon, France. And now, here are a list of our relevant disclosures, and I'll now turn things over to our first presenter, Dr. Bristow.
Thank you, Emily. Welcome, everybody. Jean-Luc and I hope you find this interesting. And so here are some learning objectives. Apply evidence-based strategies and case-based scenarios for rate control in critically ill patients with new-onset atrial fibrillation and to support safe and effective ICU management, and then explain in some detail the pharmacology of the beta-1 antagonist landiolol in terms of rate control for supraventricular arrhythmias. First, the pharmacology. We're going to talk about some of the basic pharmacology as well as clinical pharmacology here. Let's start with the indication, the FDA indication from the, let's go back here, from the prescribing information. Landiolol is indicated for the short-term reduction of ventricular rate or rate control in adults with supraventricular tachycardia, including atrial fibrillation and atrial flutter. More prescribing information, contraindications are severe sinus bradycardia or conduction system disease, decompensated heart failure, cardiogenic shock, pulmonary hypertension, at least moderate pulmonary hypertension, and a hypersensitivity history to the compound. The main thing in terms of warning and precautions, hypotension can occur. It occurs in around 10% of the patients in clinical trials. And bradycardia, any conduction system disease or a heart rate less than 60 probably is a contraindication, should be considered a precaution. I mentioned the adverse reaction. The main one has been hypotension, which occurs in 10% of the patients. So let's start with the adrenergic nervous system in terms of its role in regulating cardiac function. It's centrally positioned for that in terms of regulating heart rate and contractility. Both atria and ventricles are richly innervated with adrenergic neurons, which release norepinephrine, which is the neurotransmitter. They also, the receptors in the heart, the beta receptors in the heart, also can respond to circulating catecholamines. The major one there is epinephrine, which is released from the adrenal medulla and should be considered a hormone, not a neurotransmitter. So here are the endogenous catecholamines. Dopamine in the heart is really a precursor. It's a neurotransmitter in the brain, but a precursor in the heart. Norepinephrine is where the action is. Norepinephrine is actually mildly beta-1 selective. It has a 20-to-1 affinity of beta-1 to beta-2 and a 10-to-1 affinity for beta-1 to alpha-1 receptors. Epinephrine is non-selective for beta-1, beta-2, and alpha-1. And as I mentioned, should be considered a hormone and really is not involved in the minute-by-minute regulation of the heart. So here are the beta-1 and beta-2 receptors. There's a bunch of stuff on this slide, but you can see the binding sites for agonists termed the orthosteric binding pockets, which are similar for the beta-1 receptor on the left and the beta-2 receptor, and then antagonists, including landiolol, bind to that pocket as well as to additional allosteric sites surrounding the pocket. Importantly, both receptors have polymorphisms that affect function and can affect drug response, and there are drugs being developed essentially to take advantage of that. Shown in these peach-colored bubbles are 4 polymorphisms, 2 in each receptor. The most important polymorphism is in the beta-1 receptor at the bottom, at the 389 position, amino acid 389, which dramatically changes function of the receptor in terms of signal transduction capacity or agonist affinity, whether it's an arginine or a glycine in that position. The other polymorphisms are in the N-terminus of both the beta-1 up here, position 49 in the beta-1, and here in the beta-2, and they essentially affect internalization of the receptor. The polymorphisms essentially should be looked at as haplotypes, that is the combination of these polymorphisms in each receptor, because that's how the protein is made. And there's a lot of investigation going on now as to how to take advantage of that. Eventually, some of that may come around to landiolol. So here's the story in terms of receptor expression, protein expression in the human heart. Beta-1 receptors dominate. The numbers at the top of these bars are the percentage relative to the total of beta-1 plus beta-2. So in the non-failing heart, 75 to 80% of the receptors are beta-1. In the failing heart, there's downregulation selectively, the beta-1 receptor going down to around 60%, but is still the majority receptor. The beta-2 receptor on the right does not downregulate in heart failure, but becomes uncoupled with agonist exposure, doesn't work quite as well. But in the failing heart, it's still 60-40 beta-1 dominating to beta-2. So here are chemical structures of landiolol and esmolol, the short-acting beta blockers that are available for commercial use. They basically are short-acting because there's an ester link in the benzene ring side chain on the left in both, and that basically makes this compound susceptible, these compounds susceptible to esterases in the circulation. All beta blockers essentially have these bulky substitutions in the benzene ring side chain. And they also have lost the amino-terminus up here that norepinephrine has, and they've lost the 2 hydroxyl groups on the catechol nucleus. Essentially, landiolol and esmolol are also hydrophilic relative to the compounds on the left. And what that means is that they are cleared by the kidney, not metabolized through 2D6 in the liver. So this slide depicts several beta blockers in terms of how they were developed in terms of the generation of development, which is the classification scheme that's used for beta blockers. So the first beta blocker developed was propranolol. It basically was approved in 1967. It's a non-selective agent for beta-1 and beta-2. Then people, drug manufacturers were interested in developing cardiac selectivity, which meant going for the beta-1 receptor. So beta-1 selective compounds were developed. Bisoprolol, esmolol, landiolol are all beta-1 selective compounds. And then to deal with beta blockers and heart failure, beta blockers with vasodilator activity were developed. Some of those are shown here, carvedilol and nebivolol. And finally, there's a pharmacogenetic development of beta blockers ongoing. The first one of those is bucindolol. So landiolol is highly beta-1 selective. Actually, it's the most beta-1 selective compound commercially available. It's 216-fold selective for beta-1 and beta-2. Esmolol is 30-fold selective, so it's only mildly selective. And then nebivolol is the most selective orally available compound, 174 selective, but is still not quite as selective as landiolol. Got to go back here one. Not going back. Okay. Another important point is the molecular structure or the molecular constitution of landiolol versus esmolol. Landiolol is manufactured as the S isomer, the active isomer. There's a for all catecholamines essentially and antagonists, catecholamine antagonists. There's an S and an R isomer. And most beta blockers are commercialized or developed, manufactured as the racemate, including both the S, the active compound, and the R isomer, which has less affinity for beta blockade. Landiolol is manufactured strictly as the S enantiomer. And there's only one other beta blocker that is manufactured that way, and that's timolol. Esmolol is a mixture RS racemate essentially of both isomers. And the R isomer has less affinity for receptor blockade, beta-1 receptor blockade, but contributes to blockade of calcium channels and sodium channels, which creates a certain amount of difficulty essentially in terms of the pharmacodynamic action. So highly selective, basically with a limited negative inotropic effect. Some of that contributed, the lack of negative inotropic effect is contributed somewhat by the fact that it's the S isomer of the molecule. So both esmolol and landiolol are very rapidly acting. The half-life of elimination for landiolol is 3 to 4 minutes. It's a little bit longer for esmolol, but still short. A T1/2 shown here on the left is basically 4 minutes for landiolol. It's the same in the Japanese and the Caucasian population. Why is that important? Landiolol was actually developed first in Japan, and many of the studies were done there in a Japanese population. But it's the same pharmacokinetics and the same pharmacodynamics in European ancestry population shown here in terms of the T1/2. Now, there's some interesting differences between landiolol and esmolol, and one of them is that landiolol produces a greater reduction in heart rate compared to esmolol, shown here on the left. This is actually in rabbits, but you're going to see the same thing in humans in a few minutes. And at the same time, there is less reduction in blood pressure, shown on the right here in rabbits. Landiolol, as the dose increases, does not decrease blood pressure very much, at least in this experiment in rabbits, whereas esmolol does. So here's landiolol in healthy volunteers in a European ancestry population. Low dose, mid dose, high dose, esmolol in comparison. So the orange dots is landiolol, black is esmolol, and you can see that the reduction in heart rate at low dose, medium dose, and high dose, all reference to the doses that are in the prescribing information, is greater actually than esmolol. And by comparison, the reduction at low dose landiolol is the same as high dose esmolol, shown here in this dotted line going across. So here's a recapitulation, essentially, of the rabbit data that I showed before. So here, landiolol is in the darker colored and esmolol the lighter colored. And for heart rate reduction, and these are heart failure patients, actually, class 2 to 3 heart failure patients with mean LDS of 37%. You can see there's a greater reduction in heart rate with landiolol on the left than esmolol. And on the right, there is a lesser reduction in blood pressure with landiolol versus esmolol. So that blood pressure reduction may in fact be related to a negative inotropic effect, as shown here. We're back to rabbits here. This is a Lagendorf preparation. And so landiolol was compared to esmolol on the left as heart rate effects in response to an ongoing infusion of isoproterenol, and then landiolol or esmolol is infused on top of the isoproterenol. At similar reductions in heart rate, there is more of a reduction in blood pressure, or more of a reduction in contractility, LV DPDT on the right, with esmolol compared to landiolol. And the reason for that, according to the investigators who published this, is a negative inotropic effect by inhibiting calcium channels and possibly sodium channels, which ends up with narrowing of the action potential shown on the left, which occurs with esmolol, but not landiolol. All right, we're going to get to AF now. So my background in AF has to do with atrial fibrillation and heart failure. I'm involved in drug development in that area. And these are both atrial fibrillation and HFrEF heart failure, lower ejection fraction heart failure, has similar pathophysiologies, and the adrenergic nervous system is primarily involved in the pathophysiology of both of them. They're both related to chamber remodeling. In atrial fibrillation, that's atrial chamber, and ventricular. In heart failure or HFrEF, it's ventricular remodeling. And they basically interact back and forth. That is, when there's remodeling in the ventricle, there ends up being remodeling in the atria, for example, filling pressures rise and so forth. And then what happens is you get one, you tend to get the other, and when you get both of them, it's bad news. But in addition, in atrial fibrillation, at least new-onset atrial fibrillation, it can be shown that an adrenergic trigger is often involved. So that is special for atrial fibrillation. The actual onset of the disorder can relate to an adrenergic trigger, either a pulse and adrenergic drive, or things making adrenergic drive more sensitive. So it turns out that beta blockers not only, and landiolol certainly included, slow the rate, are good for rate control in atrial fibrillation. They also prevent atrial fibrillation modestly, let's say. And so here's data from the Merit heart failure trial with toprol XL or metoprolol CRXL, showing a reduction in atrial fibrillation in this trial by 48%. And if you go pharmacogenetic with reduction in atrial fibrillation and heart failure, you can get this risk reduction up much higher than that. So in addition to controlling rate, there is an effect on preventing subsequent development of atrial fibrillation once a patient has developed sinus rhythm potentially, although that's not part of the current indication. So I'll turn the podium over to Jean-Luc Falahi here, who will talk about real data in post-op use of landiolol.
And before Dr. Falahi begins, I just want to remind everyone who's watching that there is the Q&A chat box available. So if you have any questions, please utilize that.
Okay. Good afternoon, everyone. And thank you to give me the opportunity to share with you some information regarding postoperative AFib and how to treat it using first beta blockers. I can't move to the next slide. Okay, so the learning objectives of my lecture today are first, to understand the epidemiology of new onset AFib in acute care settings. Second, to know the different treatment options according to international guidelines. And finally, how to apply an IV short-acting super-selective beta-1 blocker strategy as first-line therapy to control rapid ventricular rate. Next slide. So, new onset AFib is a frequent complication following cardiothoracic surgery and also after non-cardiac and non-thoracic surgery and in ICU patients admitted to critical care. And this incidence has remained remarkably steady over recent decades. And not only AFib is a frequent complication, but it's also a serious complication which has been found repeatedly to increase morbidity, cardiac morbidity, cerebral, renal morbidity, to increase short and even long-term mortality, to increase length of stay in ICU and in hospital, and finally to increase healthcare costs. Numerous risk factors have been identified, and they can be divided in fixed risk factors, mainly related to patients' comorbidities and characteristics, and transient stress factors accompanying acute illness, as pain, inflammation, hypo or hypervolemia, hypo or hypertension. And these factors are for sure the most interesting or the most important for us, since they are pretty modifiable. So let's see now the treatment of new onset AFib in acute setting. Two main pillars. First, the treatment of associated factors, which is a prerequisite. It must always be done. And second, why it is important to consider a rate control strategy as the first-line therapy, the first option to treat AFib. I'm sure you're familiar and comfortable with the treatment of associated factors. Again, hypervolemia, electrolytic disturbances, especially hypokalemia, but also hypomagnesemia, and hypoxemia, anemia, covert sepsis, or positive inotropic agents. And please avoid them when possible if you want to decrease the incidence of AFib. Well, This is the single large randomized controlled trial which compared a rate control strategy and a rhythm control strategy in patients undergoing cardiac surgery. Published almost 10 years ago now, it found no significant difference between groups on the primary endpoint, which was the total number of hospital days within 60 days after surgery. And there was also no difference in the percentage of patients with no AFib at postoperative day 7. If you look at the figure, postoperative day 7, which is the frontier between paroxysmal and persistent AFib. However, as expected, the rate of reduction and return to normal sinus rhythm was faster in the rhythm control strategy group. Thus, we can say that there is no difference between both strategies in terms of efficacy. But if you look at the right part of the slide, which shows the reasons for crossover between treatment, because as crossover was allowed in the study. Those reasons are very different. Ineffectiveness was the main reason in the rate control groups. That means in the groups where beta blockers were used. And side effects of amiodarone were the main reason for crossover in the rhythm control group. Indeed, amiodarone in postoperative AFib should be used on an individual benefit risk analysis, because if we all know some advantages of the drug, the good hemodynamic tolerance, especially when given orally, or the ability to use it when LV function is reduced, or in patients receiving postoperative inotropic agents, positive inotropic agents. But there is also many disadvantages using amiodarone, and especially amiodarone is associated with numerous acute and chronic cardiac and extracardiac toxicity. And I would like to insist on the pulmonary toxicity, which has the most clinically significant impact and can lead to acute respiratory distress syndrome, refractory hypoxemia, and even death. The reason why amiodarone is contraindicated in COPD patients and in patients undergoing pneumonectomy or lung transplantation, where, as you know, the incidence of AFib is high. This is a reason why the joint American and European anesthesiologist guidelines clearly recommend both preventing and treating postoperative atrial fibrillation with beta blockers or calcium channel blockers for rate control as a first-line therapy. And amiodarone should be reserved as a second-line option. As well, the European guidelines, the guidelines from the European Society of Cardiology, are consistent with the previous ones. and also recommend beta blockers or calcium blockers when LV function is normal, above 40%, for rate control first. A combination with digoxin can be considered if necessary, and the goal is a lenient rate control with a resting heart rate below 110 beats per minute. And again, as you can see, amiodarone is reserved as a second-line treatment, especially in patients with hemodynamic instability. And finally, the recent American guidelines published last year are very similar to the European guidelines. And you can see on the right part of the slide, the algorithm showing how beta blockers or calcium blockers must be used as first-line option in the absence of heart failure, whereas amiodarone should be reserved as a second-line treatment. We just published last month a narrative review in Journal of Clinical Medicine, and we propose a synthesis algorithm for the treatment of postoperative AFib. In paroxysmal AFib, if there is an after treating, of course, associated factors, again, it's a prerequisite which should always be done. If there is no hemodynamic instability, which is the case in 90% of patients, then a lenient rate control strategy using cardioselective beta blockers should be the first-line treatment. And amiodarone may be considered only in selected patients who have either severely reduced left ventricular function or are receiving inotropic agents. Further, the decision-making process regarding rhythm control strategy for the treatment of POF, either paroxysmal or persistent postoperative atrial fibrillation, should be shared with a cardiologist because to do that, different antiarrhythmic drugs can be proposed as dronedarone, flecainide, propafenone, or sometimes amiodarone also, depending on the existence or lack of underlying either coronary or valvular or heart diseases. Which beta blocker can be used in the critical care setting? This meta-analysis of randomized controlled trials found that beta-1 super selective drugs are more effective to control heart rate without precipitating hypotension or bradycardia, meaning that their use is quite safe and probably safer than other non-selective beta blockers. However, as you can read on the right part of the slide, there are some limitation of that meta-analysis that should be underscored. Michael Bristow already showed you a pretty similar slide previously. For sure, landiolol is both the easiest and safest super selective beta-1 blocker that can be used in acute care settings because of a very short half-life, 4 minutes, a very high cardioselectivity, actually the highest cardioselectivity among beta blockers commercially available, and a good hemodynamic tolerance, especially the absence of hypotension, which was a problem, clinically speaking, I mean, when we used esmolol instead. We ran a prospective randomized study to explore the effects of dose ranging of lendiolol from 0.5 to 10 micrograms per kilogram per minute in patients after cardiac surgery. And we were interested in both macro hemodynamic parameters and also left and right systolic and diastolic functions. And what we found was very reassuring, as no significant decrease in blood pressure and in stroke volume were observed, whereas a dose-dependent decrease in heart rate was evidence, especially when the dose was of 5 micrograms per kilograms per minute. And as a consequence, this ratio E/A of the left ventricle was significantly higher, significantly increased, meaning that more time, the left ventricle had more time to fill in. And all other parameters remain unchanged, again, pointing out the safety of the drug in cardiac surgery patients. This systematic review we published in 2018 mainly shows that the use of lendiolol to control heart rate after cardiac surgery was effective, not only to slow down rapid AFib, but also to accelerate return to normal sinus rhythm when compared to any other control. This is another systematic review of 17 studies, including more than 300 patients, at the exclusion of cardiac surgery this time, patients admitted in ICU and experiencing AFib. And in those patients, the use of lendiolol was associated with a constant decrease in heart rate, ranging from 20 to 50%. The mean conversion time was quite short, less than 9 hours. The dose of lendiolol ranged from 2 to 20 micrograms per kilogram per minute, which is a low to moderate dose. And the incidence of hypotension in those ICU patients was quite reasonable, around 10%. And interestingly, the signal was consistent across all the studies, either in medical or surgical ICU patients. And the mean rate of conversion overran 70%. So to conclude, the first-line treatment of new-onset AFib in the ICU is based on rapid ventricular rate control once considering associated factors, the treatment of associated factors. Selective beta blockers should be preferred to amiodarone for both efficacy and safety reasons. And esmolol and above all lendiolol are IV short-acting super-selective beta-1 blockers with PK/PD properties that are the most appropriate in the ICU. Thank you for your attention.
Thank you to both of our speakers. This is now the portion of our Q&A portion, so if you have any questions, please drop them in the chat. Our first question is for Dr. Falahi, and the question is, what were the first types of patients that you initially utilized landiolol in, and why were other therapeutic options such as digoxin, amiodarone, and other IV beta blockers not the best options in those patients?
Sorry, the question is why?
So it's two parts. So the first question is, what were the first types of patients you initially utilized landiolol in?
Cardiac surgery patients, because I work in cardiac surgery mainly, so we first try it in cardiac surgery patients, but now it can also be used in non-cardiac and non-thoracic surgery as well.
And then the second part of the question is, why in that population were other therapeutic options such as digoxin, amiodarone, or other IV beta blockers not the best option for those patients?
But because we try to follow the recommendations, and the guidelines are pretty clear from both parts of the Atlantic, in America, in Europe. The first line therapy must be the use of beta blockers to control heart rate, mainly because it is safer for the patients than using, for instance, amiodarone, which is anyway in France, but I'm sure it's also true in America. Maybe Michael can tell that, can say that, but amiodarone is still too much used in France by care providers.
Our next question is, if you had a hemodynamically stable patient with uncontrolled atrial fibrillation, would you consider landiolol with concomitant oral or NG tube rate control?
Well, that's a good question. The question to know when stop landiolol and relay it by oral bisoprolol, for instance. That's what we do in France most often. So the idea is to use landiolol for at least 24 hours, sometimes more, and to rapidly introduce an oral beta blockers at increasing dose, and then stop landiolol when we believe the patient is truly beta blocked by the oral beta blockers.
And then as sort of a follow-up to that, would your strategy for preference for selective beta blockers change in patients who weren't hemodynamically stable, say patients with septic shock on vasopressors? Sometimes there can be concerns about doing so with the beta agonism of norepinephrine.
That's another good question. My answer is it's not a problem for us to associate landiolol and norepinephrine, you know, because the therapeutic goals are quite different. On one side, your goal is to control heart rate, and on the other side, to maintain a mean arterial blood pressure above a given threshold. However, of course, if the patient receives dobutamine, for instance, then we cannot use landiolol. And this is the situation, the clinical situation where we still use amiodarone. One of the situation. Maybe Michael, you want to add something?
Yes, thank you. Well, sort of unmentioned in this is the fact that the short action of landiolol is, you know, the risk of attempting to control rate in a very rapid response with a tenuous clinical setting can be completely reversed just by shutting off the drug. So you have very little to lose if you think you might have a shot of controlling rate in an unstable patient. But in general, you know, you don't want to use any beta blocker in, for example, septic shock, I don't believe, or someone with completely decompensated heart failure, you know, borderline cardiogenic shock. So, you know, this is all clinical judgment stuff, but the fact is that landiolol, with its short action, if you're going to consider it at all, you know, you have little to lose. You shut the drip off and it's gone.
And that's actually a really good segue into the next question we had, which is, can landiolol be utilized as an intermittent push, or given its pharmacokinetic profile, does it always have to be a continuous infusion?
Yeah, I think it makes more sense to give this as a continuous infusion. If you wanted to do a test dose, for example, in a tenuous situation, perhaps that could be done, but it makes more sense to, because of its short half-life, to give it as a continuous infusion.
I do agree. We don't use boluses, you know, we titrate by using a continuous infusion to obtain the heart rate we want to have.
And Dr. Bristow, could you remind us all what the half-life of landiolol is, as well as its routes of metabolization? Is it renally cleared, hepatically cleared, or some other mechanism?
Yeah, so it's 4-minute half-life, you know, which is really fast. That's because esterases chew up that ester linkage in the side chain. And it's hydrophilic, and so it gets cleared mostly by the kidney. And so any kind of 2D6 polymorphism that can affect other beta blockers that are more hydrophobic is not an issue with landiolol.
This question for Dr. Falahi: does your institution have a post-op AFib protocol for your CV surgery patients? And if so, what does that protocol include?
Yes, we have a written protocol now, and this protocol proposes the use of landiolol first to slow down rapid postoperative AFib, you know, and asks not to use amiodarone anyway as a first-line option, which is a huge change, you know, in practices. But now it seems to work because practitioners are have been reassured trying to use landiolol that the drug is really easy and really safe, you know. So now it's pretty, it works, and Landiolol is used, is daily used on a routine basis to slow down rapid AFib. Yes.
Dr. Bristow, I know you mentioned earlier that avoiding beta blockers in a septic shock patient is considered to be a good practice. But one of our attendees is wondering about the utilization of Landiol with norepinephrine in a septic shock patient if the patient is in atrial fibrillation and it's felt that the atrial fibrillation is not caused by a compensatory mechanism to that shock state.
You know, Jean-Luc might want to comment on this because I have not used Landiolol with norepinephrine, or actually used Landiolol at all yet. But you know, when you in septic shock, the use of norepinephrine is probably mostly as a vasopressor, although you know the cardiotonic effect also, all things being equal, is helpful. But so think about what happens here if you use them both. You're blocking the beta-1 receptor with Landiolol. Norepinephrine is occupying the beta-1 receptor, acting as an agonist, so that's going to get canceled out. But what would remain would be sort of a pure alpha-1 receptor effect and some minimal beta-2 receptor action, because the compound is not very potent for beta-2 receptors. So you would still get the vasopressor effect in a combination of Landiolol and norepinephrine. Jean-Luc, do you want to comment on that?
Yes, for sure. If you are not familiar with Landiolol, septic shock is more tricky, you know, than the postoperative cardiac surgical patients who develops a rapid AFib. But the association again of Landiolol and norepinephrine is possible. And there are some data showing that if you add Landiolol in those patients, stroke volume and blood pressure, they do not decrease. The problem is that in septic shock patients, we really don't know which heart rate should be achieved. What is the goal in terms of heart rate in those patients? For sure, we don't really know that. So the use of Landiolol in septic shock, yes, it's possible, but it's not for sure the first indication I would keep, you know, and the first message I would keep.
And then pivoting just a little bit, but still overall management of these patients, do either of you have recommendations for how to manage anticoagulation in these patients, especially if they are now rate controlled thanks to the Landiolol?
Well, in new-onset atrial fibrillation, I don't think there's an issue postoperatively with anticoagulation for a while. And the question is, how long would it take for thrombotic risk to develop? But if it's a matter of hours, it's probably not an issue. But if it goes on for days, let's say longer than 24 hours, it does become an issue. And of course, there's surgical issues to be considered too in terms of beginning anticoagulation. Jean-Luc, go ahead and take care of this one too.
Yes, of course, it's a good question, but it was out of the scope of the topic today. What I just would say is that the definite benefit-risk ratio and optimal long-term use of oral anticoagulation among patients with postoperative atrial fibrillation is not quite clear, and it should be better informed in the next future, you know, by the results of ongoing large RCTs, which are actually currently conducted in cardiac surgery and also in non-cardiac surgery. So the guidance could change in the next future, I guess. We have to wait for the results of those large studies.
Thank you. And I think this question will be for Dr. Bristow, but what adjustments, if any, need to be made for patients who are receiving continuous renal replacement therapy?
So adjustment for renal failure, is that basically the question?
Yeah, renal failure and dialysis modality.
Yeah, so I actually can't answer that, but I would say that not much. But Jean-Luc, I'll turn this over to you.
I do agree. I do agree with you, Michael. Probably not much change.
Yeah, I guess based on what you had said earlier, where it's mostly cleared by esterases, probably pretty minimal adjustments needed for CRT or renal failure, which as a pharmacist is always nice to hear.
Right.
Absolutely, absolutely.
For Dr. Falahi, what are the kind of typical drip rates that you see with Landiol?
What of typical, sorry?
The drip rates that you're seeing, like the typical infusion rates or doses that you're utilizing.
You mean a typical dose?
Yes.
Okay. Usually we start at a low dose. You mean for to prevent or to treat AFib?
I think for treating, we
for treating,
yeah,
okay. Okay, so usually we start at a pretty low dose, 5 micrograms per kilograms per minute, for instance, depending on LV function of the patients, and we titrate and progressively increase up to 10, 15, 20, and most often we don't go over 20. And if it doesn't work at 20, it can work at a higher dose, but it is quite uncommon, you know. So I will say between 5 and 20.
Thank you. And could you share just some general advice for newly onset management of flutter in the ICU, as flutter can sometimes be really difficult to abort?
Michael, you want to answer this question? Well, if the patient's unstable, a cardioversion is probably the answer to that. Yes, atrial flutter can be very difficult to treat with drugs. But I would say that starting with a beta blocker is a good place to start. You at least have a chance to slow rate to some extent, but you may not be able to slow it to the degree you want to. And then if it goes on, I think cardioversion is the next step.
Yes, I do agree, especially if you believe that the arrhythmia is responsible for hemodynamic instability, as Michael said.
Thank you. And some of our AOP partners have let us know that they have some data from Japan showing that the doses that they usually need to use of Landiol for treating flutter are a little bit higher than those that they use for atrial fibrillation.
Right.
Okay, so I think we have time for probably one more question. So our last question is that the total infusion volume of Landiol appears to have a lower total volume as compared to Esmolol. And should that be taken into consideration? Would it be patient-specific, or should volume of infused drug always be considered in these patients?
Go ahead, Jean-Luc.
It's true. The total volume is less with Lendiol than with esmolol, and it's probably a good thing in ICU patients if it's the question, because sometimes with esmolol we had to infuse large volumes of fluids, depending on the dose, of course, and it's no more a problem with Lendiol on that. So, you know, now in France, anyway, in my institution, since we have Lendiol available, we replace esmolol by Lendiol in almost all indications, except maybe aortic dissection, when we want to decrease blood pressure, because blood pressure decreases with esmolol and does not decrease with Lendiol. Do you agree, Michael?
Yes, that makes sense.
All right. Thank you so much to all of our attendees for submitting questions. That concludes our Q&A session. And thank you so much to Dr. Falahi and Dr. Bristow for joining us. Again, I would like to remind you all that this webcast is being recorded and the recording will be available for anyone who registered within 5 to 7 business days. The way you can access this is by logging into your mysccm.org, navigating to the My Learning tab, and clicking on the webcast titled Managing ICU Arrhythmias, Rapid Rate Control Strategies Using Beta-1-Selective Agents. Then you'll click on the Access button to access the recording. That concludes our presentation today. Thank you everyone for attending.